The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell with Leading Age Michigan, and we're here this morning for our weekly Safe and Calm webinar. A few updates first. We realized that we have not gotten the PowerPoint and the video to you from last week. We will do that with this week. And we also had a webinar on Monday about the Executive Order 2020-50. And we have developed a Q&A document for that. However, all of the answers have changed because the guidance has changed in the last 24 hours. So we will be getting a Q&A for that webinar out to you, hopefully by tomorrow, with the Q&A from today. So as we talk again about where we are with the pandemic and dealing with our response to the pandemic, we do note that community transmission of the virus has flattened out a bit, but issues for residential care facilities and skilled nursing facilities continue to grow, much of which is due to a lot of confusion and concern about the plan for serving COVID-19 in our post-acute and long-term care facilities here in Michigan. We always want to acknowledge the toll that we know that this pandemic has taken on our communities. Even those with few or no COVID cases to date have had to really put a lot of effort in ensuring that their patients and their employees and their residents are well taken care of. The intensity of the communications and the directives, your staffing issues, lack of supplies, decreased revenues because some people have experienced fewer admissions. We all know that that's taking a toll. And so this continues to be a very difficult challenge for our members, and we thank you every day for being the ones out in front and serving our seniors. Later in this webinar this morning, we're going to talk a little bit more about Executive Order 2020-50. But before we do so, we'd like to review some of the background for that directive. In our many discussions with MDHHS, it was clear that the goal was really to provide some capacity for post-acute and long-term services for that population because it wasn't always easy to find placement, but also to assist some providers in ensuring a safe environment for doing that, both safe for the residents and safe for also employees, staff, etc. So the resulting executive order, we understand, was an attempt to do that, but obviously the details were not fully considered in terms of the limited resources that the state actually has. And it also really exemplified the flaws in our current healthcare system, and it made some of those ideas become very difficult. So it's clear at this point that this initiative is going to continue to morph as it plays out. Members can assume, though, that COVID care in nursing homes and assisted living are going to continue to be a strong focus since our most vulnerable seniors are located there. So this morning, Dalton is going to go over some of our major messages, our advocacy messages to the state regarding the executive order and the development of these regional hubs. And I will later review the details about where the department is in that development process. We believe that as these larger issues become more defined and work themselves out, that a lot of the smaller details that seemed problematic in the beginning will sort themselves out too, because some of them will simply go away because of some final decisions that we anticipate the state will be making. Again, for today's webinar, we are asking members to submit questions all along. Blake, you can move the slide forward, please. And we will review them at the end of the content sessions. We're going to follow our routine agenda this morning, which starts with an advocacy update from Dalton. a review of COVID status in Michigan, and of course then all of the directives and memo updates that we've experienced since last week. So with that, I will turn the mic over to Dalton Herbal, who is our Director for Advocacy here at Leading Age Michigan.
Good morning, everyone. Thank you for attending this morning. I am going to sound like a broken record this morning for those who have already been on the call. I need to pass along everyone's sincere thanks from who works downtown in Lansing. Everyone's very proud of the work you all are doing and continues to express their gratitude for the work. Today, we'll be going over a couple of points, 3 in particular, regarding our advocacy asks and kind of information we've received. The first, we'll be covering Michigan's Executive Order 2020-50, kind of our large advocacy asks throughout that order. As Deanna said, she'll be going through a little bit more detail now. A lot has changed about the order, but we do also have a webinar recording from Monday and the handouts from Monday's call for everyone to review if they want to see some of that basic material regarding the order. The second piece here is going to be a conversation we were able to have with Senate Majority Leader Shirkey, his plan in the go forward, and kind of his thoughts about where Michigan stands regarding the coronavirus response. And lastly, we want to talk about some federal provider relief grants, some updates to that have just happened, and then I'll briefly touch as a bonus 4th point on what is going on with the 4th stimulus package and the additional funding provided through the PPP program at the federal level. Next slide, please. So our first point, it says define dedicated unit, but really a large theme for all these points is that we need a bit more clarity around Executive Order 2020-50. There's been a lot going on in the last week, as I'm sure you all are aware, and the terms that have been set out and the definitions in the document all don't really flow well with previous executive orders and current Michigan law. So we're asking for clarity around the order. We know the intent was to provide post-acute care capacity and safety for individuals with COVID-19 and staff who are caring for them. And so we're working closely with the department to help set up these definitions and make it easier for everyone to understand. The first point, as I said, was define dedicated units. We feel that dedicated units aren't very well defined, and we know that the department is going to be issuing guidance regarding dedicated units, the regional hubs, and actually the 80% occupancy rule in the go forward here. They said within the next 24 hours, I believe. So this can all change relatively quickly. Our second point is around regional hubs. MDHHS has stated that they understood the need to clarify the information around regional hubs, and they anticipate that the next guidance that's coming out that I mentioned will update these. It should include information such as adequate defining what the parameters are for isolated residents, what's adequate access to nurses' stations, bathing procedures, toileting procedures, supply procedures, and other procedures of the like. The department is working with the long-term care ombudsman as well to limit the liability for the providers who opt to be these regional hubs. Kind of the trade-off here, though, is that these regional hubs will be required to do enhanced reporting on a daily basis to the department. And lastly, I don't think any conversation about Executive Order 2020-50 would be complete without mentioning the 80% occupancy rule. That is going to be heavily impacted by this guidance around defining the dedicated units. If you don't know, nursing facilities with less than 80% occupancy must develop dedicated units and must accept normal admissions, whether or not those admissions were hospitalized with COVID positive patients. Obviously, this causes a lot of confusion, especially with the way it's worded. We're seeking clarity on that, and the guidance will be out in the next 24 hours or so. As the second point, I just wanted to touch briefly on a conversation we were able to have with Senator Shirkey regarding his plan for Michigan and COVID-19. He first started out presenting to the group about his estimation for what the budget shortfalls in the coming year will be and what he anticipates is going to be happening. He didn't want to speak too heavily to this because they're taking the approach that the April data, in terms of the financial data, will actually show what the true impact of COVID-19 will be rather than the March data. The March data does show some decrease in tax revenues to the state government, but the April data is really going to show a full impact and a full picture. Because of that, he didn't want to speak to 2 years away's current fiscal year, but he'll speak to the ones before that. He anticipates a $1 to $4 billion budget deficit in the current fiscal year. Leading Age has ourselves have heard $2.5 to $3 billion deficit. So we're all about on the same range there, kind of the same thing. There's a little bit more to that last one. Thank you. In the meantime, though, he has instructed the appropriations chairs to start the budgeting process now for this current fiscal year. What he's done and what they are doing is setting up a budget that automatically has a 20% reduction in funds across the board. This is just going to be a starting point, so that way they can start negotiations from a set area. It doesn't necessarily mean that just 20% is going to be taken off of everyone. It's kind of taken off in certain aspects of the budget and not in across the categories. He also commented on what his plan is to open up Michigan. As I'm sure everyone is aware by now, especially Michiganders, because of the protests, people have had to speak about what their plan is for opening up Michigan and opening up the economy. His plan is actually more in line with the governor's than one would think. He really wants Michigan to focus on testing and has been calling on legislators to enhance testing measures and wants businesses to be able to guarantee that people will be as safe out shopping and out being a customer as they would be in their own home before he is okay opening up Michigan for any kind of policy action. Some of you may have seen that the House of Representatives has set a reopening plan. Some highlights from that plan: they're going to break up the state into regions based upon county, with Oakland, Wayne, and Macomb kind of as a high-risk area. They wouldn't have any measures lifted, but the rest of the state would go under these criteria which they have set and be put into one of two buckets, either less impacted or impacted. And they would then have restrictions lifted off in time as their COVID-19 data comes out. If you're interested in that plan, please feel free to email me. I have a link to it. It's kind of interesting. We don't actually know if that'll be the plan in the go forward, so it's just kind of for fun. Okay, next slide, please. So some brief background on Medicare and Medicaid attestations. The U.S. Department of Health and Human Services coordinating the provider relief grants through the CARES Act. Phase one of those grants provided funds to facilities based on fee-for-service, Medicare fee-for-service revenue during 2019. The grants do not have to be repaid, but facilities are responsible for their use as they are intended to offset additional costs related to COVID. There are also, HHS that is working on a reporting mechanism that providers must sign and attest to that they will use those funds for COVID-19 expenses within 30 days of receiving those funds. In a second wave of grant funding, HHS is looking to support facilities who don't receive Medicare fee-for-service funding, but do receive Medicaid funding, and that includes assisted living providers. But since the Medicaid program is administered by states, HHS is struggling to know who those providers are and has asked Leading Age Michigan for assistance to identify those providers. Anyone who has received an email from Dave asking you to attest to what your TI, I think it's TT or TIN number is. Please complete that and submit that to Leading Age National. They are compiling all the data and will be submitting that to HHS to make sure that the funding goes out appropriately. Recently, there has been some extra payment conditions added on to these funds, kind of to force providers to use those funds for COVID-19 relief. Some of the highlights are that they have to use the funds for preparation activities and responses to the pandemic that include diagnosing, testing, treating individuals with suspected or confirmed COVID-19 diagnoses. They must not use the payments to cover expenses or losses that have been reimbursed from other sources. They must not be used to pay any salary or compensation in excess of $197,300. If a salary does exceed that amount, they must supplement those funds with non-relief fund money, and they must not collect out-of-pocket payments greater than what the patient would have had to pay if care had been provided by an in-network provider. And then kind of this fourth bonus point, I just wanted to provide a quick reminder that in the recently released fourth stimulus package approved by Congress and President Trump, there was additional funding and forgivable loans added to the Paycheck Protection Program, or PPP. For members who may not have previously applied, as we know the funding ran out rather quickly, we would encourage you to go to our website and take a quick look at our reference guide, which Deanna will show where that is later in the presentation, to see all the grants and funding opportunities available to you. This is an interesting program. It's certainly something to take advantage of if you have the opportunity. Once on our website, you can open up our reference tab. From there, scroll down to COVID-19, click on it, and on the center of the page, you'll find a link to grants, loans, and advanced payment opportunities. Deanna will demonstrate this process later. And with that, I'll take any questions that anyone would have.
All right. Is it still the understanding that the 80% rule applies only to skilled nursing facilities and not HFA's AFC communities?
Yes, right now that is the understanding. Deanna?
Yes. But I would also ask that we hold the questions about the Executive Order 2020-50 because we do have more information about that later. So if we could confine the questions to other advocacy, I think at this point that would be good. I do have several slides later that talk about where we are in terms of those that program.
Okay. Can the Medicare money be used to fund lost revenue or just additional expenses?
I can take that, Dalton.
Okay.
My understanding is that it's actual expenses. I do not believe that there's any provisions in there to fund lost revenue.
Okay. To clarify, the Medicare grant funds need to be fully spent within 30 days, or do we just need to allocate them towards COVID-related expenses over the remainder of the outbreak?
The 30-day requirement is for signing the attestation. You can, of course, identify your costs and expenses related to COVID care across that whole pandemic period.
All right, and then I don't see any other questions. I do have something I think this would, it's not necessarily about advocacy, but it wasn't another question. I would assume this is more towards you, Deanna. It says EMTs and doctors are training residents at AL and SNFs in Oakland County and refusing to take seriously ill residents, requiring more intense care due to deteriorating conditions. The residents and family requested to go to the hospital. Is this a violation of resident rights?
Okay, I'm going to ask you to repeat that because I didn't get the beginning very well. So can you repeat that question?
Yeah. EMTs and doctors are, triaging EMTs and doctors are triaging residents at AL and SNFs in Oakland County and refusing to take seriously ill residents, requiring more intense care due to deteriorating conditions. The residents and family requested to go to the hospital. Is this a violation of resident rights?
Well, I think that there are several issues there, and we are going to talk about this a little bit later because there really doesn't seem to be good alternatives. In fact, there's clearly not good alternatives, especially for persons in assisted living level settings. Is it a violation of resident rights? I would say not technically, because you are not violating anyone's resident rights. And they do have the ability to triage and identify where the priorities are, given what the capacity is and the resources available for their community. So I think this is a huge dilemma, and one that we're talking to the state about, because as they have kind of changed a lot of the parameters included in that original executive order, and changed not necessarily the definition, but the primary work of the regional hubs, it does feel to me as if assisted living level settings don't have any good options here. So I don't have a good answer for that. I can only say that we continue to talk to the state about how we're going to serve all of the senior population who are, number one, at risk, and number two, having issues with the virus.
All right, and then that is all the questions I have right now, so we will move forward.
Okay, great. So we're going to talk about our statistics a little bit, and you can move right to the next slide, Dalton. Very briefly, as of Monday, this slide shows the total number of U.S. tests provided, the number positive, and the number of deaths. And if you look closely, you can see that the number of positive cases leveled off a bit. And that's the graph, the kind of orangey graph at the bottom. But also, it seems like the number of tests, which is that gray bar at the top, are leveling off in the U.S. as well. In Michigan, we see more and more focus on testing and more initiatives to expand testing. So I'm not sure why it looks different across the U.S. Maybe there are areas where they think that the transmission has decreased enough to limit some testing. But we do know that in Detroit, the health department has performed over 1,200 tests just in nursing homes alone in the recent days. We don't know the results of that, but I would anticipate in Michigan we're going to see more testing as we move forward. So this graph is similar to ones that I put up before. It shows the 7-day rolling average, which is kind of a good way to ensure that you're not looking at day-to-day variation. But you can see that the United States continues to top the chart. But it is good news because you can see that graph is leveling out. These are the number of new cases as well. This chart I had not seen before, and I thought it was pretty interesting. It just kind of gives you a picture of how the virus has kind of spread, because it is time on the horizontal axis. So you can see that the fuchsia colored, kind of reddish pink color, is the United States, that we had a late start. But at this point, the U.S. Accounts for an awful lot of the deaths that's occurring worldwide right now. In fact, 30%. It does look like we have perhaps on a downward slope, and that, of course, is a very good sign. As a state, it's also good that we've moved from the number 3 spot to the number 5 spot, following New York, New Jersey, Massachusetts, and Pennsylvania. At one point, you know, we were number 3, and I was afraid we were even going to grow higher than that. So we look like we are definitely flattening that curve. So in Michigan, and I think this was as of Monday, you will see that we have 32,000 cases, 2,468 deaths. There do continue to be concerns, though, in Michigan and elsewhere, as more and more research is showing that with the limited testing that's out there, the number of unreported and asymptomatic cases is probably larger than we thought. So although these numbers look like they're flattening out and they look good, there can be an awful lot of community transmission out there yet. This is our daily growth in cumulative cases. I had to shorten this graph and just go from starting on April 1, since I've had too much data there. You'll notice there was a slight uptick yesterday, but in general, it's good to report that we're going down. This is the daily growth in Michigan COVID deaths, and it looks like we had a huge increase yesterday, but that's really kind of misleading. The state goes through on a routine basis all of the death certificates and kind of batches the number of cases that they consider were not reported originally as COVID deaths, and they were added to the death list as of yesterday. So all of those increases in deaths did not occur over a 24-hour period. So now on to recent updates and directives, guidance, emergency orders, etc. We'll start with the CDC. The CDC put out several updates to its guidance, but a lot of those updates have the same basic theme. They simply updated each of their numerous numbers of guides and pages on their website based on this general theme. And I don't think that this change will impact members very much. It's about universal source control, meaning that because of the large amount of community transmission, it's not so easy to identify how the virus is being transmitted, but to assume that everyone is infected. Well, measures taken by CMS and the Michigan Department of Health and Human Services have already assumed that, which is why we're already doing universal screening. We've already completely restricted all but a few visitors, and staff and visitors are already required to wear face coverings, and that's pretty much what this guidance is now recommending everybody do. So it's kind of behind what the work of CMS and Michigan has already done. So focus here is on the fact that while cloth coverings are most helpful when they are preventing transmission, and that's what source control is preventing transmission from a person who could be infected to another. They don't necessarily prevent infection, so that if I'm wearing a cloth mask and caring for a resident who is COVID positive, there's some risk there. What's more likely to happen is that I, as a person, am not going to infect someone very easily if I'm wearing a cloth mask. So face masks are still recommended for direct care staff, and 95 respirators are recommended for direct care of COVID patients, and cloth masks are suitable for visitors or non-direct care staff, again, trying to protect the residents from the staff. The CDC also notes that these directives are hard if there are not enough supplies, and of course they always go back to the suggestions for conserving your resources. So the CDC also made some changes to the criteria for staff to return to work. They didn't change very much. Previously, they had published both a test-based strategy and a non-test-based strategy. Now they want to make sure that their preference is that people use a test-based strategy and exclude from work anyone who has a positive diagnosis, and they must wait until all of their fever and other symptoms are gone without the use of meds, and they also want a negative testing result. They also know that that's a preference and that the ability to get tested might still challenge that. The non-test strategies are still appropriate but not preferred, and they include really pretty much no symptoms for 72 hours and at least 7 days since symptoms first appeared. They did include a new guideline for COVID staff without any COVID positive staff without any symptoms. They only need to be excluded from work for 10 days, but only as long as symptoms never appeared. If they ever got symptoms, then you have to treat them like the other in the other categories. And I did include where these the actual page that these updates are from on the left side of your screen. So for suspected or confirmed patients, again, it just restates a lot of what was said in the other updates. Again, they want to implement source control, things that we've already done in Michigan. In this update guidance, they want to remind everyone that cloth coverings are not PPE, and that face masks should really be used and reserved for direct care workers. Cloth coverings may be appropriate, again, for visitors. They can use a face mask if there are no other options, obviously. And a reminder that there needs to be a continued strong focus on actively screening all visitors and staff and residents, actually. Transmission risk. They have made some brief updates to transmission risk as well. And a lot of this is, again, based on the idea that there's growing evidence that persons, there's a lot more persons out in the community who are asymptomatic and don't know that they have the disease, and that there is also some evidence that a lot of transmission probably occurs before any symptoms appear. So they want everyone to continue their focus on social distancing. They've changed the period of risk for contact tracing from when the symptoms occurred to 48 hours before the symptoms. And that really is a new piece. However, I would have thought that they would want to track contacts before symptoms appeared anyway. So I was really surprised at that one a little bit. They talk about contact tracing a lot, and I'm not sure how much our facilities or the health system is doing that, but I do know that there are a lot of initiatives right now at the state to increase contact tracing, and in fact, they're working on contracts right now with groups to perform some contact tracing. I think this is a major piece for the governor to have completed before she's willing to really looking at opening the state. Facilities should continue to emphasize reporting exposures and ongoing monitoring. And we want to remind everyone that the CDC does have a page that has additional guidance on mitigating staffing shortages. I don't think there's anything surprising there, but it is a helpful list if you are struggling with staff. There are some ideas there. So mitigating staffing shortages. They've updated that language to kind of align with the universal source control issues. They do identify the difference between staffing issues at a contingency level and a crisis capacity level. And again, there is a good list of ideas there. And the only difference between contingency and crisis is that at crisis level, you start to think about whether or not you have to move your residents somewhere else where they can be served. But again, it is a good reminder list if people are struggling. So this piece was new to me. It came out with the updates of the CDC guidance. So right now, I know that members are struggling. They all have to report to the local health department. Right now, SNFs have to report starting this week to the Department of Health and Human Services. We know that CMS plans for at least SNFs to report to the CDC in the near future, although they haven't defined how to do that yet. And now here's a note from the FDA, the Food and Drug Administration. So apparently there's a rule out there that anyone who is providing chloroquine for COVID-19 from the national stockpile must report any med errors or serious adverse events and clinical outcomes to the FDA. They also encourage anyone who is providing treatment for COVID-19 to also report any med errors and serious adverse events. So I just wanted to put that out there. I had not heard this before. I saw it with the updates and thought it might be of interest. I don't know if anyone's treating anyone with chloroquine, but just in case. So CMS updates. Last week, CMS put out QSO 2026, and it is mostly about transparency and reporting. The reporting is meant to be sent to the CDC. There's absolutely no further information about that, how that will be done, or what data specifically has to be reported. But they do make it very clear that failure to report will result in enforcement actions. Also, they focus on the need for continued surveillance in nursing facilities. So there's a huge focus on infection control and how you're managing your program. Last but certainly not least, and this is current now, the resident and family notifications have been updated. So providers, members are required to inform residents or their representatives within 12 hours of each confirmed case of COVID-19. Or if there are 3 or more residents and or staff with symptoms that occur in a 72-hour period time frame, also have to be reported to residents and families and staff. So I know that that's a lot of communication, but I think that there's been a lot of concern out there about nursing homes that might not be doing this, might not be doing adequate reporting to families. So I do know that some of our members are challenged by this. However, right now it is a rule. So I want to just take a moment here and talk about AFCs and HFAs because I have some concerns about the fact that there's no clear guidance, and in fact, with some changes in how the Executive Order 2020-50 is going to be implemented, is almost silent on how to care for persons in those facilities. The Bureau of Community and Healthcare Systems was planning an update to their frequently asked questions. It was in progress before the executive order came out, and then they were telling us that they were waiting for clarifications from the department. Well, now that AFCs and HFAs have pretty much been eliminated from the regional hub discussion, the dedicated unit discussion as we anticipated, we don't know how, if someone requires care in your facility but doesn't require medical attention and is a positive COVID patient, how you are expected to perhaps isolate and protect the rest of your facility. And I know that there's a lot of concern about your ability to do that. So again, as I said earlier, this is something that we'll be talking to the state about. The reporting requirements identified in the executive order are now also on hold for AFCs and HFAs. They were in the executive order, they were in the press release, but the updated order from the actual department, not necessarily the governor, has put all that on hold now. The regional hubs will be taking transitions from hospitals and other nursing homes, but not other residential care settings. So that was a surprise to me, to be honest with you. So we'll have to see how that plays out and what the department's plan is for AFCs and HFAs. So we do know that they are struggling with an awful lot of detail. We do know that this is going to continue to morph, and the planning is still in its formative stages, so hopefully we will get better guidance. So the executive order itself, obviously the goals were to increase capacity and provide safe environments. But at this point, they are taking transfers from hospitals and other nursing facilities only. There are 3 regional hubs confirmed at this time, but only 3. They are required to have certain structural elements that support isolating a unit, and they will be looking at workflows, access to supplies, access to a nurse's station, access to baths and toilets, etc. So there are some requirements that are going to be needed if you want to be a regional hub. So they feel that confining the movement to regional hubs from hospitals and from other nursing facilities will allow them to study, consider the capacity needs, refine the operational requirements, look at the risks for serving. It kind of allows them to do a demonstration project. They did let us know that they are trying to limit the provider liability as a regional hub. They have not confirmed anything yet, but they're hoping to do so. These regional hubs are going to have to provide enhanced reporting on a daily basis. And this is one thing that I want to maybe provide a little bit more detail on compared to what Dalton was saying earlier. My understanding is that in the next 24 hours, only the guidelines for the regional hub is going to be issued. There's an awful lot of discussion going on about the other 2 pieces, which is the guidance for hospital transfers and transitions and how to use the regional hubs in a larger environment and what a dedicated unit looks like. I think that they are struggling to some degree with a lot of the detail there, and I don't anticipate that they are coming in the next day. Hopefully they'll be coming soon, but my understanding is that there was no time frame set for that. So we can anticipate a lot of further changes coming down the road. So reporting requirements were also included in the executive order from last week. The press release from April 20 was an error. The press release stated that HFAs and AFCs also had to report through EM resource. The department has clarified that that's not true, and it is not included in the actual order that they put out on Monday. So at this time, only SNFs are required to do that. So it is a reminder, though, that all residential and post-acute care facilities do still have to report to the local health department within 24 hours of identification of any COVID-affected residents. And I don't know why this is in there because I think it's self-evident, but they must transfer those in need of medical care to hospitals unless directed otherwise by advance directives. The advance directives piece was not specified in the executive order. That came in a follow-up memo on Monday. SNF reporting starting yesterday was for 2 indicators. There is a additional reporting that is expected toward the end of this week, and that is a lot more detailed. We will send out the draft list of elements that the department is considering, but my understanding at this point that is draft. We will send it out with this PowerPoint after the program. So also in the emergency order that the department put out on Monday, they identified the creation of what they're calling IPRATs, Infection Prevention Resource and Assessment Teams. They are intended to work with nursing facilities to prevent and contain COVID as much as possible. So there's 2 avenues they're going to do that. They're going to reach out to non-COVID facilities in order to stop it from moving there, or at least identifying it early. But they will also reach out to facilities with vacillating infection rates. So their work will also include focused reviews of infection control programs, policies, procedures, trainings and protocols to staff, contact tracing, again, that's coming up again. And they also included remote facilitation of use of a self-assessment tool that I think is a CDC product called Tele-ICAR. I've not seen this tool, but they are talking about that in terms of one of the resources that they would suggest for SNFs moving forward. So that kind of completes our discussion about the guidances and the directives. Any questions about that?
All right, before we get into any questions, I need to unmute Dave really quick. He said that he has an MDHHS statement to read, so give me 1 second. I need to find him on here. Okay, so I am unmuting you right now, Dave, so you should be good to talk whenever.
Good morning, Blake. Good morning, everybody. And Deanna and Dalton, great job so far, as always. Just wanted to share with you a quick note that had just come in from Elizabeth Hertel and Director Massey, and it relates to additional testing. You know, certainly, as you know, the state's concerned about PPE and additional testing. But Elizabeth wanted to share with everyone that there's a laboratory called NextGen in West Michigan that's evidently stood up some additional capacity and will be able to do a lot of the testing of your consumers with a 48-hour turnaround. And they just want to make sure that everybody is aware of that and that could get out to folks as quickly as possible. So we'll certainly be sending the additional information along with today's PowerPoint, but I did want to share that with everyone while we had the opportunity this morning. So thank you, Blake, and you can put me back on mute.
All right, sounds good. Thank you for that. So I do have a list of questions here. Let me grab those. The first one is, we've been hearing that some COVID negative facilities have implemented the use of face shields along with masks for all resident interactions. Have you heard of this? Would you recommend this as a proactive way to keep COVID out? Obviously, this depends on the supply of face shields, but we have enough that each staff member could be assigned one and reuse it after disinfection.
My understanding is that face shields are very effective as long as they are accompanied by face masks of some degree. They are definitely, I think, better for eye protection. I do believe that they also help if you don't have enough face masks themselves and are using cloth coverings. It's suggested that you use a face shield. So I do think if you have access to them, they are a higher level of protection.
All right. Do we have any update as when the CDC will release the form for standardized reporting of COVID-19 residents in nursing homes?
No, to be honest with you, I've not heard anything and I have no idea. It could be tomorrow, it could be next month. I mean, you never know.
Okay. Are cloth face masks appropriate for dietary staff who are not preparing food but or who are preparing food but not interacting with residents?
My understanding is that it's really only people who are interacting directly with residents that should be wearing a face mask. So I do believe that would be adequate.
Is the reporting to staff and residents or families or residents and families? I'm trying to think of.
I think I understand the point of that question. I think that this would be the same as any reporting or communication that you need to have with residents. The resident, needs to be the primary receiver of information. However, we do know that sometimes residents will not be able to understand. So I would always also include families when you when there is a family or an identified representative. But also remember that some residents will not be able to manage any kind of information. So it is both, my understanding is, with the understanding that that doesn't always work out.
Are HFAs required to report supplies of PPE to MDHHS? If so, is there a way to do that outlined somewhere?
No, that's the part that has not been implemented yet by the department. Right now, at this point, only SNFs are required to do that. Nursing facilities are required to do that. I anticipate that they might down the road. They were included in the executive order, but at this point, they do not have to. And thus, there is no evidence for it.
Okay. Who do we notify at MDHHS of positive COVID?
I think that you're doing that through your reporting through EM Resource. So as you report through EM Resource, that is right now your mechanism for reporting the number of COVID cases you have.
Okay. Do we know the names of the 3 confirmed regional hubs?
I do not. I have no idea, in fact. I think that's very fluid. I think those are confirmed, but I think that they're in discussions with a lot of others, and we have not received an updated list at all.
Okay. For residents who are out of their rooms, will not wear a face mask, would there be a citation for this?
Well, I think it would depend on, a case-by-case review. I can't be sure. I do believe that residents out of their rooms are supposed to be wearing face masks. We do know that that's sometimes hard with persons with dementia. Remember that when staff are in the rooms, residents are supposed to be have some sort of face covering over their nose and mouth, if nothing else, a tissue. And we also know that that's a challenge. So whether or not you get a citation, I think would be dependent on the circumstances, but it is a requirement that when they're out of their rooms, they have a face mask.
All right. Can you please expand on the notification of all residents and families with new cases?
Well, I can only tell you what the directive says to date, which is for every single case of COVID. It's written kind of funny, but I read it that for every case that is identified as confirmed, you must notify residents and families within 12 hours of that identification. So I don't know if there doesn't seem to be rules about how you do that. I think it's going to be a little bit challenging to get out a notice to all of your families or residents within 12 hours, but that is the requirement. And then the other piece is that you also have to notify residents and families if there is a group of staff and or residents that have developed respiratory symptoms within a time frame of 72 hours. Now, I find that a little challenging myself, because if I have to identify a 72-hour period, I always have to, it's a rolling idea. You always have to look back 72 hours and did you have 3 residents and or staff? I think that that's a little hard to operationalize. I mean, it's not impossible, but it's hard. So at any given moment, I guess you're going to have to go back 72 hours and see what's been reported. And then you also have to notify residents and families within 12 hours of those.
All right. So, so we do not need to report to licensing manager, simply EM Resource. And who is EM Resource?
It is a established, known avenue for reporting, I think, through the local health department and care coalitions, but this data is going directly to the state as well. If you do not currently have access to EM Resource, you have to go through your local health department and or healthcare coalition to get access, and they can give you more directions at that point. For right now, there's only 2 level of, there's 2 measures that you're including. One is for PPE and one is for COVID cases, but there are more measures, again, as I said, that are in draft form. and we're going to send out that list after with the resources for this webinar.
All right. Can you discuss the updates to residents' families weekly?
That's not what the directive says.
Okay, and then will this PowerPoint be able right after the webinar? I'm assuming that it will probably be sent out tomorrow, would be my guess, something like that. Is that right, Deanna?
Well, actually, we identified part of, I think, it was a coordination problem on my part. We've been sending out all three things at one time. And so if one thing gets held up, we've not been sending the others. So I think that we will change that. We will send the PowerPoint and the video out as soon as we can the day. We might not get to the Q&A till the next day or so.
All right, sounds good.
So we'll work on.
If a letter is mailed out to families within 12 hours for notification, would that be sufficient, or do they need to have the info within 12 hours? We use emails, but we have several families who have not provided an email address.
I think considering that you have limited communication with residents and families, that's more than adequate. I don't know how they could ask you to do more than that. So, I mean, I think that if a written letter is your only avenue, I certainly don't think that you need to call someone at 10 o'clock at night within a 12-hour period to make sure that they know that you have 3 persons who have respiratory symptoms. So, yes, I think that's more than adequate.
All right. Weekly updates are referenced in QSO 2026. Updates must be provided weekly or each subsequent time a confirmed infection of COVID.
I do remember that. I apologize. Let me go back through that. So let me go back and I will address that in the Q&A. My apologies.
All right, it looks like that was the last question, so I think we can go ahead and move forward here.
Okay, so as Dalton was telling you earlier, there is an update to the provider grant funding that we were discussing in terms of our our updates on our website. The attestations will have a certain amount of elements in them that are required. And we have developed on our website an area that summarizes all the recent changes to these guidances and updates. So what we're going to do now is we're going to, Blake is going to help me put up our website so I can show you specifically where they are and how you can use them. Because I think that we've developed a tool that would be very helpful, especially considering a lot of the guidances are so repetitive. So Blake, I have the website up on my site. Can people see it yet or no?
No, so I'm going to make you the presenter right now, so you should see something pop up on your screen asking to show or show your screen, something like that, and you'll just have to confirm it if you're like ready.
Yes. Did that do it?
Yep, now everybody can see it.
Okay, great. So as this is our landing page for COVID-19 tools and resources. It can be accessed right off of the banner from our basic leading age page. You can see the address, it's not very hard at the top there. And our first section has summaries of major guidance and regulation. So if we go back to what Dalton was talking about earlier, those are grants, loans, and advanced funding opportunities. And so what will come up, it'll take a second. What will come up is this document here. And this is a summary of all of the guidance to date about all of the different programs that members can access. And when there's an update to that information, you will see it in the middle of the provider relief funding piece. It is about the attestation requirements, and it will be in green. So that we can update these pieces without giving you a whole new document all the time. We will also have those updates as they're written and as they come out in a different area, but we are using this to perhaps streamline the information for you so it's a little bit easier to look at. So going back to here, another good example of this is the CDC guidance. So we put together kind of like a running document that includes all of the pertinent CDC guidance that you might want to look at. So it's updated as of 4/20. These are the critical pieces for all long-term care facilities, not just nursing homes. It talks about evaluation and testing, and it includes the updates here. And those are also, you noted, highlighted in green. So as pieces are updated, you can see that you can review the updates along with the current guidance as it is listed. One of the reasons why I did this, and we worked together to do this, is because, to be honest with you, I had a hard time negotiating all the CDC care sites. I could not always find something that I was looking for. So it took us a little bit of time, but I think that this is a helpful tool, and we want to make sure that you know where you can find it. So the state department and LAURA updates are included. Now, those are really only at this point the updates that we have addressed that weren't, some of them are repetitive, but we will be adding a few more to those in the near future. The Michigan executive orders are all here as well. So these are all summary documents that if you want a review of like everything to date that has come out in any of these areas, it will be here. The only thing that is missing so far are the CMS guidance, and we're working on that as it is. Following that on the website, we have our webinar series. It includes not only the webinars that we do on Wednesday, but all of our topical series. It also includes the PowerPoint and program information for past series that if you want to review those, and the upcoming series. For all of these, you only have to register once. Recent updates, I always include daily a list of the cases and the deaths that are occurring in Michigan. And then last but not certainly least, this is where we file things that come out by date. So the CDC updates verbatim by date would be listed there. I do want to point out that we have a section called Lift Up through Leading Age Michigan, which is a set of tools and resources from members and authorities regarding COVID-19 policies, draft letters, templates, etc. That might be helpful to some members. We don't have a whole lot of policies and procedures from member to member. So we are always looking for people who think that they have a good policy or a good idea to share. And we ask that you share that with others, either through the listserv or you can send it to Safe and Calm, the email address. So that's all I have for you today. If there are no further questions, I want to thank you for your attendance, and we will try to get these resources out to you as soon as possible.
All right, I do have another question that just popped up.
I have one last thing too, if you don't mind, Blake. I forgot to mention, sorry to take everyone's head back to my section of the presentation here, but in our conversations with Senator Shirkey, we did get specific attention put on to our asks surrounding creative uses for the CMP funding pool. His team is looking closely into that, and we're working closely with them. So hopefully something creative to help reimburse people for their COVID costs using those CMP funds will be coming out shortly.
All right. And then the last question that looks like I had, has the best efforts tool been created yet? It was discussed on Monday.
No, no. The best efforts for, I need to be reminded, I think there were a couple ideas on Monday. One of them was 2 tools that came out from Dyke McGossett. Those tools are created, and if that's what you're referring to, we can send those out today. Yes,
Yeah, she said that's what she was referring to.
yes, I do remember now. But there was another best efforts tool, and you'll have to forgive me. There's a lot of stuff in my head that we don't have. But yes, those documents will be coming out.
All right.
And in fact, they may be on the web. They may be on the website already. I think Ellie may have put them on the website already, but I'll check. And that would be under Lift Up with Leading Age.
Okay. Is that statement about CMP funds specific to a request for Michigan funds, or is that a request for all states?
That's specific to Michigan funds.
Yes, we've asked specifically to access the CMP funds in order to relieve some of our members' financial pressures.
All right, and it doesn't look like any other questions are coming in. So thank you to Deanna, thank you to Dalton, and thank you to Dave as well for joining in. Thank you to all of our members. We had a total of 88 attendees at one point today. So thank you to everyone that took their time out of their busy days to join us for today's webinar. We appreciate everything you do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. As always, feel free to reach out to any of us, and we will try to get back to you as soon as we can with as much info as possible. Thank you, and have a great rest of your day.